Good morning, ladies and gentlemen. Welcome along to the Insight Seminar. My name is Cameron Francis from Dovetail. I am both MC and presenter for today. So thank you for joining us. Before we kick off, I'd like to acknowledge the traditional owners of the land that we're meeting on today and pay respects to elders past, present and emerging. Just for a little bit of housekeeping, for those of us online, type your questions in. We'll take note of them and do our best to answer them at the end of the presentation. So I think that's all we need to say. Okay. Let's get into it. Okay. For those who don't know about Dovetail, we're a little project based here at Biala, just down the hallway, providing clinical advice and professional support to workers, services and communities across Queensland who engage with young people affected by alcohol and other drug use. Check out our website, dovetail.org.au, for more information about what we do. Today's presentation is going to be about a research project that Dovetail has undertaken. So for those online, we'll drop a link to for you to download that resource into the chat window, but we'll also have it available on our website by the end of the week as well. So this is our presentation today. Firstly, I'll say that most of this work has been undertaken by Dovetail's psychologist, Cassie Davis, who can't be with us today because she's on a secondment. So I'm presenting mostly Cassie's work today, so I hope I do it justice. What we've tried to do in this project is we wanted to have a look at the characteristics of young people who are in youth AOD specialist treatment. And it sounds like a fairly easy task to do that, but actually it's a little bit complicated. So I wanted to show you this firstly, just because one of the problems we've got with looking at this population group is defining exactly who is in specialised AOD treatment, because it's quite blurry at the edges. And I think it's blurry for adults, but probably more so for the youth population. So this graphic comes from the Australian Institute of Health and Welfare. When they published the NMDS, National Minimum Data Set treatment data, they put this in there just to show us where the specialised AOD treatment services sit within the broader health and human service landscape. So what the data I'm going to show you is from a census we conducted of young people in youth AOD treatment, but we know there are young people who would be getting treatment for predominantly AOD problems who are not in our specialist treatment sector. They could be in a youth service, they could be in a housing service, a residential care provider. They could actually be in all different kinds of settings that don't look like specialised youth drug and alcohol treatment, but the work that's going on is focused around that. So there's I know that there's been some work done to estimate, how many people are outside of our sort of scope, and it's hard for us to really know that. So I just wanted to flag this to start with, that the population we've looked at are in Queensland health-funded youth AOD treatment. There probably are more young people outside of that. And so how representative our sample is actually a little bit hard for us to be super accurate on. But I wanted to show you, before I show you the results of the Queensland census, I want to show you who's in treatment in Queensland generally. And this is from the NMDS data from 2017-18. So Queensland tracks in the middle there. We're pretty average across the other states. We had 33,000 estimated clients aged over 10 in treatment across Queensland in 2017-18. Keeping in mind there's probably more than that number actually receiving treatment at GPs and other sorts of settings. So we track about average compared to the other states around Australia. And this is the age groups of young people in AOD treatment in Queensland. So these age ranges don't exactly correlate with age ranges we prefer, but you can see that the predominant age is that 20 to 29-year-old age group. Some of this data this is NMDS data. We know our NMDS data in Queensland is skewed by diversion, particularly cannabis diversion. And so cannabis diversion tends to go towards that younger age group and skews our population a little bit. But you can see there, it's about 17% of the people in treatment in Queensland are aged 10 to 19, and then it's about 27% are aged 20 to 29. The other slide I want to show you is the principal drug of concern for people in treatment in Queensland. And again, we're skewed by cannabis diversion, probably overrepresenting cannabis there, but cannabis, alcohol pretty closely followed by amphetamines, the other drugs being much lower down the list. So, what's going on for Queensland young people in AOD treatment? I'll take you through the story of what we did and what we found. So the Youth Need Census was firstly developed by YSAS in Victoria, and they conducted it back in, I think it was 2013 was the first time that YSAS did that. What they did in Victoria was basically select a nominal day of the year, and they asked youth AOD workers to complete a survey of all the open cases that they had open on that one particular day to get a snapshot of the characteristics of young people in treatment. It's called the Youth Need Census because part of the aim of it is to understand what are the needs of the client group that are in our treatment system. One thing that we tried to do in the census was to look at what the needs of the young people might be, and then what actual services are they receiving, to track what sort of gap is there between their needs and what we're actually providing to them. So we were pretty impressed with YSAS's work on that in 2013 and thought, let's team up with them and do a Queensland version. So we've worked really closely with our colleagues at YSAS, particularly Karen Hallam, but also Aura Landman and Jessica Cooten, who invented the census back in 2013 as well. So Victoria conducted exactly the same study that we did. Theirs was completed in 2016. We did ours the following year. So we have got a bit of comparison with Victoria. There's a few differences though between our Queensland and Victorian system. The most stark of which is the Victorian system has got like a very wide range of treatment options for young people. And when we looked at their treatment options, we just went, no, we don't have all of that. So we're a little bit more limited, which may change some of that comparison data as well. So what we did, as I said, we wanted to get a snapshot of young people who are in treatment. We were looking at young people aged 12 to 25 because that sort of aligns with the funding guidelines here in Queensland. And it was all open cases on a nominal day, which we chose to be relatively representative day. So the day we selected was a day in May. We got a bunch of services involved, and we tried to make sure we had representation in the regional areas as well as in the metro area. So there's our list of agencies. We also had a few Aboriginal and Torres Strait Islander specific services included. That we did limit it to Queensland Health funded youth AOD services, just so that for us to keep it a bit more contained. Also, this being our first attempt at doing this sort of research, we wanted to do it in a scale that we could actually achieve and then look at going broader next time. There are obviously other services in Queensland that will be treating young people aged under 18. There are some services now have a policy of seeing everyone aged 12 plus. They may not even have a youth-specific worker. So some of the young people in treatment are sort of just mixed in with our general treatment system, and we haven't teased that out in this study at this stage, but we'll maybe do it next time. So the date we chose was 22nd of May 2017. We tried to choose a date that was pretty boring. No major public holidays. It wasn't school holidays or anything like that. So we figured that that's a relatively representative sort of day. The survey was completed by the young person's key worker. The workers were given a 2-week time frame after the date of the 22nd of May. They were given 2 weeks to complete their data entry. And there was an online survey which they were asked to complete, which had 61 questions on it. So each worker, it took them between sort of 10 to 15 minutes to complete each survey. So actually a relatively large time impost on workers asking them to do that because some people had very large caseloads. And we did get some feedback from a couple of services that it took them ages to do that because they were having to pull a giant pile of files. So I think we'll keep that in mind for next time as well. I'll also mention too, we got ethics approval through the Royal Brisbane Hospital Ethics Committee and then all the relevant HHS ethics committees. One of our learnings, I hate that word, was that the difficulties in getting ethics approval across multiple HHSs, because what we found was that they had really quite different understandings of things. And we got, some very easy approvals in some regions and some extremely complicated approvals in others, which did end up taking us almost 6 months to get the ethics approval, which was a very important lesson for us for next time. But once we were finished, what did we get? So we got 508 young people had data entered for them. We skewed towards males, about just under 2/3 males and then 1/3 females. We had a very small number of gender diverse clients identified. The small number of gender diverse clients meant that due to confidentiality concerns, we actually had to leave them out of the analysis because the number was too small. So this is our age breakdown of young people in treatment. Not too many surprises here. The predominant age was 18 to 25, followed by 16 to 17, and that 12 to 15-year-old age group being the smallest component. We sort of expected that breakdown. We do get that feedback from the workforce. Our population groups breakdown, we got 41% Aboriginal and Torres Strait Islander young people, which again is, as I say, it's probably not representative of the whole treatment sample. We have got Aboriginal, Torres Strait Islander specific services submitting data, so that probably skewed us a little bit towards Aboriginal, Torres Strait Islander young people. 5% LGBTIQ+, and we got 6% culturally and linguistically diverse. I will say we expected slightly higher numbers on the LGBT and the culturally and linguistically diverse population group. So one of the findings we're a little bit interested in is why that number seems potentially a little low, and what do we need to do around improving access for those particular population groups. So this is a breakdown of the regions and the percentage of clients. Metro North well represented, although Cairns and Hinterland outdid everybody. So nice work, Cairns. Metro South, Gold Coast, we've got a nice spread. Unfortunately missed out on Central West and Southwest Queensland. At the time we completed this, there were actually no youth AOD workers in Southwest, and Central West we also didn't have a specific worker as well. So next time we'll try and get every single region if we can, but that's our breakdown. The length of treatment, this was really interesting. So again, this is just on a nominal day. So you're going to get a mixture of clients who it's their first appointment. But this was something we found really interesting. Majority of young people were in treatment for relatively short periods of time, under 10 weeks. We then got another group that were in treatment from about 3 months up to almost a year. But then we get nearly 20% in treatment for more than a year. And we did have one in treatment for 300 plus weeks. Which we did go and check with that service in case it was a mistake, but it wasn't a mistake. Actually, that was a young person who'd been a client of a service from a very young age and had retained engagement with that service for a long period of time. If you have a look at the actual census, which you can either download off our website, when we look at this displayed in a graph, there's a bimodal peak. So it does go very high at the beginning and then the number drops before increasing at the end in this long-term client group, the 51 plus week group. We're very interested in that group, and there's a lot of impacts on our service system for that group. We know that when we've got particularly models of service that might try to limit treatment to 8 sessions of CBT, for example, we can now say, well, we've got 20% of our cohort who need significantly longer treatment than that. So we did do a bit of a zoom in on who are they and what are the characteristics of that long-term treatment group and why are they different to the rest. So what we found in this long-term client group is we found really high rates of alcohol use and high rates of alcohol dependence reported in that group. Not super surprising. We also found that group was the most likely to report a history of injecting drug use and exposure to more severe alcohol and other drug-related harms. So it sounds like it's good that they remain in treatment. They appear to need to be there. They also had really high rates of family relationship problems and significant trauma backgrounds, abuse, neglect, and family violence. Also very high levels of involvement of child protection system, acute housing instability, and high rates of unemployment. So you might call it the burger with the works. We got all of the major complex problems that people talk about. Our workers in the sector have always said this, that we've got this high proportion of young people with multiple and complex needs requiring long-term treatment. But here we are able to actually define it and say, well, this is who they are and this is what they look like. So we asked the workers to report on what substances their young people had used in the past 4 weeks. So these are not necessarily drugs of concern, but this is just what substances the young people had been using. Cannabis being the most common, followed by tobacco and alcohol. Our methamphetamine rates were not that high. We did anticipate it being a little bit higher than that, but not that high. And you can see all of the rest of the results there. Now, again, one of the issues with this, and something we're really fascinated by, is that this is worker reports. So this would vary based on where the client is in the treatment process. If a client is a long-term client who's been engaging regularly, the worker may not be regularly reassessing what drugs have you just recently taken. That is often what people might do early on in the treatment process in their assessment, but once they're an ongoing long-term client, workers may not always be tracking exactly what drugs have they recently taken. So we are interested in talking with workers about how they do that ongoing assessment and keep a track of the different patterns over time. This was the substances that young people are using daily. So this is, again, probably a little more accurate. We think the workers would be probably onto this one. Tobacco being most common, followed by cannabis, alcohol by nearly 15%, which is a little bit higher than I anticipated, actually, daily alcohol use in that group. We generally don't see huge rates of sort of alcohol dependence in young people, except in this particular cohort, obviously we do. We also got just under 5% of daily meth use and 3% prescription drugs, non-opioid, which is not prescribed by a doctor. That's prescription medication misuse. We then asked the workers to tell us what substance the young people were dependent on. This is a tricky question because the range of different services have different measures for that. So Queensland Health is using different tools to some of the NGO agencies. So we didn't specify by what scale you have to use. We just said, tell us what your client is has a substance dependence on. Again, very high rates of cannabis. The interesting thing for me was that there's a big gap between the numbers of young people who are reported to be smoking tobacco daily versus those reported to be dependent on it, which is interesting. I'd be guessing if they're smoking tobacco every day that they are actually dependent on it, but it does demonstrate that our workforce is not particularly attuned to tobacco dependence as a thing. We have known this for a while, that tobacco, especially in youth services, is seen as, the least of their problems. We'll deal with that down the track kind of thing. And I think that this graph sort of reveals that. So one of the outcomes that we've got is to focus on tobacco in our workforce a little bit more. We got 13% reporting alcohol dependence. Not bad, given that 14.5% were said to be drinking every single day. So no, that's not too bad. And you can see the rest of the stats there. So some of the differences that we noticed amongst the various trends, we did find some really fascinating differences. Like the inhalant stats were really interesting. We always knew that young people are sort of more likely to be using inhalants than older people. We found that to be very stark. So that 12 to 15-year-old age group were the vast majority of the ones using inhalants. But then the female-male ratio is also really fascinating, 10% versus 1%. This is something that services have anecdotally reported to us in the past, a higher prevalence of females using inhalants. There's some geographical variations on that. I know that here in southeast Queensland, services report a pretty equal 50-50 mixture, but in far north Queensland, it's often reported as being predominantly female. We're really unsure as to why that is. Is it around treatment seeking, or is there an actual trend in who uses what different substances? We're not exactly sure what it is around that, but we're very interested in exploring more. We also found high rates of tobacco smoking in the culturally and linguistically diverse population group by a significant margin. Our LGBTIQ group, which was a relatively small sample, but they did have much higher rates of prescription drug misuse compared to all of the other population groups as well, which was interesting. We also found that the Aboriginal and Torres Strait Islander subgroup had higher rates of inhalant use versus non-Indigenous, and our methamphetamine using group were the older population, the over 18s most commonly. And again, that aligns with what workers had been reporting to us, is that, yeah, some young people do use meth, but it generally is that over 18 group. We found 18% of our cohort had ever injected any substance. This is an interesting one for us to track over time, and it's one that we're interested in looking at when we repeat the census, whenever that might be, because we know that since methamphetamine or crystal methamphetamine has gone out through regional Queensland, that there's been an increase in young people injecting, but in regional areas in particular. So we're quite interested in that statistic. Again, it did skew towards that long-term client group, were the ones most likely to be injecting, but also it skewed towards the slightly older group who are more likely to be using methamphetamine. 32% of our sample reported serious AOD harms, and these were things like having to be hospitalised, but it was also engaging in high-risk behaviour while under the influence of illicit of substances as well. So we did a bit of work on that group too. The mental health stats, these are also quite interesting. 46% of the sample were reported to have a current mental health problem. There wasn't a massive gap between then the number of those who were receiving a service for those problems, and we weren't exactly able to tease out whether that service was being delivered in-house by their actual AOD worker or externally. Some workers would say that they may have reported that their service is managing this, but it might be mental health who are down the hallway. So we weren't exactly able to tease out who's dealing with that in-house or not. But the next two stats were ones that we found quite shocking. Deliberate self-harm, probably not that shocking at 1/3 of the group, but 25% had attempted suicide in our cohort at some time in their lifetime. And that figure is significantly higher than the Victorian sample. This is one that stood out for us quite starkly and is very different to the Victorian stat. Out of the 25% who did attempt suicide, it was about 16% required hospital treatment for their attempt, so relatively serious attempts as well. This is one of the major sort of findings for us was actually this suicide attempt statistic and what we need to do about it. We've dug into it as much as we could, and the major predictor of that group, the most common predictor of the suicide attempt, was LGBTIQ status. Our Aboriginal and Torres Strait Islander group was actually at lower risk of having a suicide attempt compared to the non-Indigenous group as well, which was interesting. But it was the LGBTIQ group in particular that had that high rates of suicide attempts. So 57% had previously accessed a mental health service, and there were 35% currently accessing a mental health service. So a little bit surprising on that. We expected there to be quite a large gap. We thought there'd be a whole bunch with mental health problems identified but not getting a service for it. But actually, there wasn't a massive gap between those two, probably meaning that our youth AOD workers are managing a bunch of those mental health problems in-house, I'd be guessing. We asked then about a whole range of different trauma experiences has the young person ever experienced the following sorts of issues? And again, not super surprising, we did see quite high rates of neglect and physical abuse, emotional abuse being most common, also family violence experiences as well, 17% reporting sexual abuse. The thing though that I was really fascinated by was the unsure answers on this one, was workers reporting that they don't know whether their young person has got a trauma background. So in some cases, the unsures were higher than the reported rates as well. The sexual abuse stat being the highest of the unsures, to us indicates that our workforce are quite uncomfortable talking about it and asking those questions, and that the assessment around that is probably something we need to explore more. I can understand that if it's a client on their first contact, you may not go through the full history, but 20% of our sample have been in treatment for more than a year. So you'd think with those really long-term clients, our workers should have a really good understanding of their background. There were a few other little interesting numbers underneath this. There was much higher rates of unsure regarding sexual abuse reported amongst Aboriginal and Torres Strait Islander clients compared to non-Indigenous clients, where the unsure rate for sexual abuse in particular was quite different between those two groups. So it obviously shows us that there may be some extra work that needs to go into that as well. We asked about, has your client ever been involved with a child protection system in their lifetime? We got 26% said yes, 43% no, but 31% unsure. And again, I was a bit disappointed. I was like, come on, guys, we really need to know who's had that past history of involvement in the child protection system. We did see higher rates of child safety involvement in the historical involvement in the Aboriginal and Torres Strait Islander subgroup. We then asked about current involvement. So this is, are you on an order or having active child safety intervention at the moment? And it was 14% said yes, although 15% unsure. You should know if your clients are on an order, usually. Although this may reflect we do have services that are more of an open access drop-in model. And so some of these contacts might have been quite casual contacts through the drop-in where that wouldn't have been assessed. Slightly higher rates for our Aboriginal and Torres Strait Islander subgroup again. This question was, now family problems was defined as, different types of conflict within the family. We did see the youngest age group were the ones having the most significant family conflict. Our thinking is sort of that the older they get, they step away from their families, that they disengage from their families and therefore report the family conflict is not there anymore. But the youngest age groups reported current family problems, as you can see there. We also asked about involvement in criminal justice system ever in their lifetime. 54% yes or 34% no, which was sort of interesting. Again, 10% weren't sure. But then we asked about involvement in the last 4 weeks. So this would be young people who've either appeared in court in the last 4 weeks or are on a current youth justice order. About 40% said that they were having current involvement in the criminal justice system. That's really useful for us because one of the things we wanted to understand was how much does our cohort overlap with child safety and youth justice. This kind of shows us we're overlapping with youth justice a lot more than we are with child safety, which is sort of interesting. There's a few ugly stats in this one as well. The level of school engagement was off a cliff. It was extremely low. Most young people had no engagement with school, had no current enrolment, hadn't been to school for a significant period of time. 19% were reported as being homeless and 77% unemployed, although I expected it was going to be actually higher than that, the unemployment figure. The school engagement, though, there were some regional variations on that figure across Queensland. It's definitely something we're really interested in. We know that school is a protective factor for reducing substance problems, and school disengagement is a risk factor for future drug problems as well. So we've, for a long time now, had a really strong focus on schooling and keeping young people engaged in schooling. And I think this has shown us that we've got a fair bit more work to go in that domain. So look at the time. I've raced through it. We do have to say some thank yous to all of our services who are involved for putting in all of this hard work in entering all of this data, because it's a lot of a big effort to put onto services to do that. So we have got print copies of the report for services, which we'll be posting out in the next day or so. So everyone who's watching online who participated, you'll get your copy by the end of the week. So thank you very much for participating in our census. The next steps for us, what we've done is looked at these outcomes in terms of a bit of a work plan for Dovetail of what are our big ticket items that we really need to focus on with our workforce. And trauma is one of them, and how trauma is assessed in agencies is a really big topic that we need to address. Also, assessing and responding to suicide risk is another one. And I know that we've had some trouble understanding that in the past around how is it that alcohol and other drug use interfaces with suicide attempts. This has shown us that we've really got some work to do on that one. Tobacco is another one that we want to focus on, that there are some real issues with tobacco, and a continued engagement with our schooling education system to keep young people engaged in school, or to help services to re-engage their young people back into school once they've started to get a bit of stability for them. So that's probably our next steps on all of this. That's been really quick. Do we have any questions? We might go to questions in the room firstly, and then we'll throw to the online. No questions. Excellent. Any questions from our webinar audience? No?
When do you plan to hold your next census, Cameron?
We're still just recovering from the last one. We would like to do this again. I think it's a big ask on the services, and it's also a big ask on us, because I should also thank the Department of Health, who generously provided a small amount of money to assist with the analysis. It's something that we could probably only realistically achieve every 3 or maybe 4 years, because the ethics approval for us, just ethics alone, took us 6 months to do that. And then the analysis was also extremely complicated because YSAS did the analysis for us. But what we found was that the differences in our systems between Victoria and Queensland is actually so big that we really had to go back and reanalyze a lot of data with a very particular Queensland lens on it, because there just are differences in our systems that didn't quite align. So it was a significant amount of work. It was actually a little bit more work than we thought it would be, which is why it took us a while to get it out. So I can't exactly answer when we would do it next. We'd like to align with Victoria. So Victoria, they've done theirs, I think, 3 years apart. So ideally, if we could sync up with the Victorians, that would be nice, because then if we are able to compare our states, that would be really useful. I think in the future, when we do it again, I think what we'll probably do is also start looking at a few of the questions, the NMDS questions as well, so we can start to compare more easily against that larger treatment data pool as well, and link those two things up. So I can't answer exactly when. Yes, it might depend on when funding might be made available.
Well, most of those prescription drugs, were they benzos or?
So the question from the floor is, the prescription drugs, were they benzos? We don't exactly know that. The question they were asked is prescription drugs not opioid or prescription drug opioid. So they were the two classifications that were used. I think next time we'd like to unpack that a little bit more and find out more, because I think we're really interested in that prescription drug misuse. We know we've had a big increase in like fake Xanax, counterfeit Xanax in Queensland as well, but we can't really see that in the data that we had. So that's something we'll improve on next time.
There's a question about whether or not organisations have access to training that relates to responding or asking about trauma in the youth AOD setting.
Well, yes, there is. That's a great question. There's an excellent workshop called Trauma Informed Care, which is run by Insight and Dovetail. So the Trauma Informed Care workshops, if you have a look at the Insight website, it has got the calendar with where the Trauma Informed Care workshops are being delivered. It's a relatively new workshop and it's extremely popular. So it does book out really, really quickly, but it has been and is currently touring around the state as well. So keep an eye on the Insight website for dates for the next Trauma Informed Care workshop.
It's being run in Sunshine Coast today.
Sunshine Coast today, there you go. Yeah, but have a look, and you should really subscribe to Insight's website mailing list, because those trauma workshops have been booking out within a week of them being launched. So we've got heaps more training to do in that area.
And I believe another trauma toolkit's on its way as well.
That's correct. Trauma toolkit is on the way. Thanks for reminding me, Jeff. That'll be online with a whole bunch of different trauma videos and resources and tools and things.
Have any other jurisdictions beside Victoria and Queensland expressed interest in similar census type work?
No, they haven't actually, not yet. But we did have, when we first started, we were a little naive. We were like, this should be Australia-wide. Let's get every state involved. And then we realised how hard it was for Queensland to do it, and thought, like, let's just take it one at a time. But ultimately, what I think it is actually quite tricky to do something like that, because our treatment systems are so different, even between Queensland and Victoria. And we've worked with YSAS from Dovetail's inception, so we had a good understanding of their system. We weren't quite prepared for just how different it is until we start looking at the data and the numbers. So if we were to look at the New South Wales treatment system, for example, is a completely different landscape again. So it's actually much harder for us to do than we thought.
The school engagement question was that only up to 18-year-olds, like in terms of that stat of 18%?
Yes.
That was counted for within the age ranges.
Yes.
Would you include youth justice in the next census?
Not specifically. So I believe that Youth Justice have have their own census, which they do as an internal project to look at their young people. So there are other sectors that do similar pieces of work, and I'm aware that that does occur. But we're very keen to look at. I mean, part of the reason we did this survey was there was two reasons. It was because our youth AOD workforce constantly tell us that their client group is complex, that the system managers don't always understand the complexity of their client group, that they're engaged in multiple different services and systems and things. And people keep telling us that. So we wanted to show that. We wanted to help show the system managers that. But it was also a bit selfishly for Dovetail for us to work out what are the actual needs of the youth AOD workers out there. What are they seeing every day, and what are the characteristics of the clients? So we did keep it narrowly focused around drug treatment for that reason.
I think you have answered all the questions. So please join me in thanking Cameron Francis.